Welcome to the Eyecare Experts, Dr. Bell, Dr. Teresa, and we're here. What's the topic of today? We're going to talk a little bit about low vision, because certainly, patients have, whether it's central low vision, maybe peripheral vision issues. Sometimes it's a congenital or genetic disease that causes them to be this way, and sometimes maybe it's a progressive disease that's something that happens later in life. But it's not as simple sometimes with these patients as, hey, here's a pair of glasses. Sometimes it helps, but sometimes we need to do a little bit more to try to help them to see or, magnify things or give them any advantage that we can.
They get very frustrated in dealing with what other people consider normal problems, but to them, they're huge issues that sometimes we can only fit a few of them with something that helps them, but that's better than nothing.
Well, I graduated, I'm not going to tell you what year I graduated, but I graduated from Optometry School, Southern College in Memphis, Tennessee, and we did a lot of training in low vision and vision therapy. And sometimes, certainly these exams, these patients, it takes a little bit longer. It's not as simple as, hey, read the 20/20 line, hey, here's your pair of glasses. So we understand that. There's when we break down low vision, I guess for me, I kind of think of it as, hey, is it a central vision loss? Is it something like maybe macular degeneration where it's causing you not to see, in your line of sight straight ahead? Or is it more peripheral defect? And we talk about glaucoma. We've talked about glaucoma a lot in some of our past podcasts. And that's what glaucoma does. That's one of the things that certainly it's a progressive disease that takes away your side or your peripheral vision over years and years. But there's other things too. There's night blindness. There's other things that can affect the retina, whether it's retinitis pigmentosa. There's a lot of congenital and retinal defects that certainly would limit the peripheral side vision.
I agree. The basic thing is to find out where the loss is first. That's the first step. And really, low vision doesn't concentrate on what you've lost. It's like with any problem. You can't change the past, but you can look at what vision is left and maximize what you have left and use it to the best of your ability. And certainly all the new technology is amazing on what it can do. And to be honest with you, I'm not even familiar because there are so many new kinds that come out and patients mention them to me, and then I Google them and tell them what I think of that. But I can tell them if for their condition that is what they need or that is what they should invest in. But you can also order it through our office, and we have a thing where we just have the price online and get it in and see if it's appropriate for you, and we can screen that for you. And that comes with your visit when we analyze what kind of loss you have.
Well, I think, certainly, and we're talking about how to help them as far as treatment plans, but step one is to figure out exactly what vision loss you have. Is it complete central? Is it partial central? Is it your left visual field you can't see? So unless we, do the full exam and maybe do additional testing to figure out and document that, we don't know whether it's prisms, whether it's a magnifier, kind of what's going to be best to help you. But that's the reason we do that. We do full exams, we do dilations, we have OCTs, we have visual fields, we have ERGs, we have a lot of things that kind of help us diagnose and see exactly where you're having the issue or where you can't see. A, we want to know that to help you, but B, we want to know that because we want to make sure it's not progressive and getting worse over time. And that's something we can document and have a baseline, so over time we can see if it's getting worse, especially with glaucoma patients and things like that. We want to make sure it's stable and not getting worse over time.
And I think it's important to note that older patients who many of these diseases, they succumb to these diseases, that they're not as technology friendly as the rest of society, and therefore adapting older techniques to them, they generally feel more comfortable with that, like they feel like reading a book as opposed to reading a text from their phone.
Well, I talked a little bit about glaucoma, but when I first graduated school, and I don't, as far as age-related macular degeneration, we hear a lot about nowadays, especially genetically and family history of it and testing for it to see, you know, what's the likelihood you would have macular degeneration if your mom or your grandma or whatever had it. But when I first graduated school, all we really had was vitamins and supplements to offer patients. And we've come a long way with that as far as, you know, whether it's anti-VEGF injections, different treatment protocol, where a lot of these patients, not only have we sometimes stopped the progression of the macular degeneration, sometimes it's even actually given patients better vision. I know retina is doing a lot of patients that see macular degeneration, that have macular degeneration.
Well, it's the #1 cause of blindness in the United States, and you have to remember that 40, 50 years ago, it wasn't even on the map, and hardly anybody talked about it because it was a relatively rare disease. And yet it went from nowhere to #1. And so a lot of research has concentrated on that, as you can see from the TV ads.
The other thing, and this is one thing we harp on with diabetic patients, and they're, you know, we've got a really good relationship, I think, with primary care and specialists nowadays, where, you know, everyone kind of sees the value of checking the health of the eye, especially for diabetic patients. Because we can tell a lot by looking in the back as far as, you know, whether it's the arteries and veins, as far as leakage of blood or fluid. We can see, hey, are they very controlled or moderate, severe diabetic retinopathy? And with these patients, if we can catch it early enough, usually we can help them before it becomes a permanent vision loss. And so that's the reason it's so critical for any diabetic patient to at least have the once-a-year complete eye exam. And if there's things that are going on, we may see you every 3 months, every 6 months, every 9 months. And certainly, so hopefully you never get to the point where you lose the vision, your side vision, or lose all your vision. I've had some patients that, unfortunately, that have gone almost blind from being diabetic.
Yes, that's the second leading cause of blindness in the United States. And a lot of that is preventable. And that's better than treating it from the low vision approach of let's build on what you have left. But at some point, that's your only option.
So if you haven't had an eye exam lately, and hey, you've got blurry vision for whatever reason, you're like, man, I could see last week or last month, but for some reason now it's all blurry. Well, it could be blood sugar shifts, it could be bleeding, it could be a lot of things going on. So, patients who are going to the hospital, or you have a very, your malignant hypertension or your blood sugar's uncontrolled, that's even more reason for you to come in and get that eye exam so we can look in there. And of course, we want to get you seeing the best we can, but we also want to prevent any partial or permanent vision loss now or in the future. So diabetic retinopathy is key. Cataracts is something we talk an awful lot about, and certainly we talk about age-related cataracts. So, in Florida, most of us are in the sunlight or UV light over years and years, and probably will develop some sort of cataracts. But when we talk about low vision cataracts, it could be let's say there's an infant or a kid who's born with a cataract. And if that's not discovered at an early age, or at least addressed, the patient could become amblyopic, meaning they can't see out of that eye. It becomes a lazy eye because they say they can see okay and normal out of this eye, but this eye has a very bad cataract they can't see. And if it's not addressed, the longer it stays there, sometimes the less chance that eye will ever see as good as the other eye.
And there's been new technology for that and detection of that, and the implant lenses have all been upgraded. And again, catching that problem early is the key part of the solution.
Well, I think one thing you said earlier is, a lot of these patients, we cannot get you 20/20. You hear that a lot. Do you see 20/20? Well, for these patients, it's just getting them to see 20, whatever the best we can get them. 20 happy. If it gets them to be able to function and see their normal daily activities, that's the goal. Maybe it's a patient who can't see, to their left, and maybe we put prism in the glasses where it moves the image over, so they don't have to turn their head, as much to see because they can't see in that direction. So there's a lot of things we can do in our office. There's sometimes places we can refer you to, if you need a magnifier or you need to blow up something, enlarge it just to be able to see it. So we want you to kind of start with us, and if we can't do it ourselves, we'll certainly get you referred or get you sent to someone that can certainly address or take care of that visual need.
Yeah, there are clinics specifically for that in complicated cases. A big one is in Birmingham, at the University of Alabama in Birmingham, their low vision clinic. And we've referred patients up there for services that they couldn't get anywhere else.
Well, I think the moral here is just like we usually say for most things, is come in. Come in for that annual eye exam. If you're seeing something that's weird or off and, hey, you know, this is something in my vision that I haven't seen or it's alarming, if it bothers you, it bothers us. And we want to find out what's the cause of it. And maybe we can help you on the front end and maybe it never becomes a problem. Or maybe, hey, you have, you know, macular degeneration or you have glaucoma or whatever you have. We want to manage you because the treatment is usually nothing to lose sleep over. The treatment for glaucoma is a lot of times just eye drops. Maybe it's a grid we give you to take home, or nowadays we actually have computer programs where you can self-assess any progression with the macula.
It's amazing. They have, and we use this, it's called 4C Home, and it's an artificial intelligence program that you have a small, gosh, the size of a food blender at your house that tests you for it. You can do it daily if you like, and it sends it into a center in Virginia, and then if the results are not what they should be, they will send me an email. Then I'll look at it and have the patient come in right then, and if they need referral, then send them to a retina doctor for full assessment because it's an emergency case. A lot of things occur in between visits. So normally it would take 6 months or 3 months or 9 months in between visits. And many of those accidents occur in that timeline, whereas this thing at your house will pick it up under those conditions. So it's important to monitor, especially the #1 cause of blindness.
Well, a lot of these patients that, you know, reference-wise, is maybe they've already lost vision in one eye or they're partial loss and they've got one good eye. And I mean, when you're in that situation, I mean, the slightest change in the good eye, you know, we want to make sure that that good eye doesn't become what the other eye is. And so the earlier we can pick up, you know, any macular progression, maybe change them from dry to wet or even going from mild to moderate or moderate to severe, you know, we can get you to the right person or maybe a retinal specialist or what have you to save the vision you have in that good or the remaining eye.
One of the best new instruments to do that is an ERG or an electroretinogram. It's similar to the EKG for your heart. And this will tell whether the cells in there are under stress or not, which there's no other way to assess that function. So if a person is monocular, that is, sees only with one eye, and you run that test on them, and you see that that system is under stress, then you've got to talk about a preventive move by either their GP, their retina doc, if we refer them, or however that's going to work, but at least you know the system is under stress. Without that test, you can't tell.
Well, I know I get in the clinic, I get questions pretty much, if not every day, every other day, as far as, hey, my mom has macular degeneration or my dad has glaucoma, you know, what are the chances? It doesn't mean that you're necessarily going to get it, but it does increase your chances. And so we want to look at that really good to see, you know, kind of your nerve size now and make sure that's not changing over time. For macular degeneration, I tell patients this, and I don't know what the textbook says, but you know, most of the time I see macular degeneration, it's in patients who are late 50s, maybe 60 years of age. So even if you had a full exam and you were 35 or you were 40 or you were 50 and everything was great, it doesn't mean it's going to be great for the rest of your life. And so these are things that we need to watch and monitor and over time look at to see, hey, maybe 5 years ago you didn't have any problems, but now you have some drusen forming in the macula, or maybe you have early signs of macular changes, and maybe we need to start you on some lutein or supplements or whatever. And so just make sure you're coming in regularly, because 5 years ago was 5 years ago, but things can change quickly when it comes to the eye and the health of the eye.
Well, the technology in this area is amazing. There's a machine that tests via virtual reality for not only the, well, you look in a camera or in the back of the eye with certain lenses, and you can tell if the patient has macular degeneration, but you can't tell if he's going to get it. So these virtual reality tests can predict up to 2 years prior to seeing physical evidence of this disease, whether you're going to get it or not. So if you're clean on that test, you're in pretty good shape. However, even though I look in there and say, oh, you're fine, if that machine can predict it with greater accuracy at an earlier point in the disease, you know where you're headed, you can make plans for that, and you can start dealing with that situation when you know it at an earlier point.
Well, the other thing I get to, besides, hey, what's the chances of me getting it, is, hey, let's say my grandmother or my mom, if she's taking supplements, she's taking vitamins, whether it's Preservision, Ocuvite, or some other, AREDS 2 formula, should I go ahead and take it? And I don't know what your answer is to that, but what I usually say, it certainly wouldn't hurt you to go ahead and start on it, but from the studies that I've read, there's nothing that says, hey, you should start on it before we start seeing early signs or detections of things that are forming in the macula. So what I usually tell patients is, hey, let's watch it closely. At the first sign I see something changing, or maybe the start of drusen or something like that, then we would go ahead and start you on those supplements to help. But as far as starting when you're 20 or 25 and everything looks healthy, I mean, you certainly could do it. There's really not a downside, but that's a lot of money to spend to take, a vitamin twice a day for 20 or 30 years.
It's even more than that. Yeah. So AREDS has the studies that studied those supplements. They switched from AREDS 1 to AREDS 2. And the reason why they switched was AREDS 1 contained a substance called beta-carotene. And it turned out if you were a smoker, that beta-carotene would predispose you to developing certain types of lung cancer. And so here you were taking a supplement thinking you were helping yourself, and in fact, because you were smoking, the beta-carotene was counterproductive in your lung tissue. So that's why they switched to AREDS 2.
So just be aware, and that's something we will discuss with you as far as, hey, are you a smoker? Which vitamin or supplement might be the best one for you to take, yield you the best results. But yeah, just low vision is the topic. Again, a lot of things that contribute to it. Come in. We certainly want to see you for that exam. We want to kind of document, give us a baseline as far as what your loss is, and figure out the best way to treat you and to help you to see, to be able to function for whatever it is that you do, any daily activity you have. We want to try to make that the best that we can. But again, I'm Dr. Bell, Dr. Teresa. Thanks for watching the podcast. Stay tuned for future episodes. Let us know if there's any topics you'd like for us to discuss. But in general, we thank you, we enjoy it, and we wouldn't be doing this if it wasn't for you guys. Thank you.